Good evening, everyone. I want to welcome you all to the Central Valley Telehealth Symposium 2023, Breaking Barriers to Healthcare Success. So I'm so excited to welcome you all to the symposium. Mohammed, can we have some more? Thank you. So welcome you all to the Telehealth Symposium, and I wanted to share with you my journey regarding telehealth. I started thinking about telehealth way back in 2019, not realizing that the world would change and it would change forever. So I wanted to kind of welcome you all to kind of have this conversation getting started post-pandemic. What are the changes and the realities that are upon us that we can, collectively come together? And that's why, I'm just so excited to put together a panel and the keynote speaker here today to talk about some of the challenges, some of the wins, and some of the opportunities that we can bring together and collectively think about what is the path forward, right? So that is the motive and the precedence of this meeting today, to realize what we have to do moving forward. So with that, I want to talk about a few things. So I wanted to thank few people, and I want to start by, thanking Dean Schubert. She's the one with whom, I couldn't knock on her door because it was a pandemic. But, I entered a Zoom meeting and there was Dean Schubert, and I wanted to talk to her about, I'm just passionate about this subject and I feel that there is so much need in the Valley. And, she just supported me so much to realize and, connecting me with Dr. Mohammed Rahman, who is the wheels and the leg of this journey that I'm taking together regarding telehealth. I also wanted to acknowledge my department chair. She's not here today, Dr. Jenna Swaddenby, and she was the one who connected me to Dean Schubert. So, it's so helpful when, the young faculty is being supported. So, that is an example of that. I also wanted to thank Dr. Kara Sografos, and, she is being the special assistant to the dean. And ever since I've met Kara, I've realized how humble and kind she is. And, I just so thankful for, being there with me on this journey. So this event is kind of sponsored and supported by all these three entities. So thank you to all the departments and the College of Health and Human Services. So again, this is our interprofessional team working on telehealth for student education and training. And this is an interprofessional team that's, again, we started to put together, and I kind of connected with Mohammed, and, he's right there. And then from the Department of Physical Therapy, Dr. Cheryl Hickey and Leslie Zernkam. From the nursing department, I had Dr. Eileen, and I have Dr. Herkirba. And from the social work, we had Candice Madrigal. So I wanted to acknowledge these professors who are working day and night in understanding and realizing the importance of this work. So this is my, gig with telehealth. I wanted to acknowledge Dr. Hana Ko. She's back in there. And I was, like I said, I was talking about telehealth in 2019, but that's when, when 2020, March 2020 hit, we are like, okay, we have a gait balance and mobility clinic, and me and Hana kind of co-direct that. But you're like, what should we do? We can't have the patients go back. They so much rely on us. That is the social support, that is the physical therapy support that they need. And, within I would say few days, we just turned our in-person gait balance and mobility clinic into a telehealth clinic, imagine with the gait balance capabilities. So we definitely thought, outside the box there, and, it made us realize that, not all physical therapists and not all physical therapy entities have to be in person. You can do a lot of things in a hybrid model, or in that particular case, an online model. So I was, trying to kind of think about what should I think in terms of breaking barriers for healthcare access, and I come across this 2013 study. And that is so relevant and important today. It talks about how you can think about the challenges and make them into opportunities. What are the things that you can think of in terms of converting the challenges, whether it is respect to the policy, whether it's respect to the business model, whether it's respect to the therapy. So I think this study kind of talks about that telehealth cannot be a side gig. It is a healthcare issue. It cannot be a side hustle. It has to be mainstream. And that is what I'm here to advocate for, that let's not think of it like a side gig. It is something that has to become mainstream. Yes, I do realize that we have to do a lot of things in person, and telehealth is not the answer for everything. It is not like one size fits all. But we do have to realize, and with all the great minds sitting in this room with me, I want to start those conversations, those pilot programs, what we can do with the Fresno County. What are the things that our patients are experiencing, and what we can change for them in terms of healthcare access. And finally, this is the moment to really put our brains together. There's a think tank sitting in our room from Kaiser, from Fresno County, from Public Health Department, from Valley Children's. I am envisioning, and I am trying to manifest a telehealth center for the Central Valley here, and if we put our brains together, if we put our resources together, I think there are so many things that we can do. We have to just be, clever and creative about the opportunities that we can create for our students who can become the task force, and they are the task force that's coming up in the pipeline. So that is what I'm envisioning today. And I'm so excited to welcome you all and get this telehealth symposium started. So with that, I want to call Mohammed. He's going to talk about why do we need that in the Central Valley. Mohammed, please, your hands put together for Mohammed.
Change. See. Very good late evening, late afternoon, early evening, late afternoon. Thank you for being here, and thanks Nupur for getting this started. And as she said, our goal is to have a telehealth center where different partners in from the Valley can come together, and we can build a better better place for patients and practitioners in the Central Valley. Today, I'm going to talk about a few things. Number one, talk about access to broadband, because that's critical for telehealth. Number two, talk about use of telehealth from practitioners and patients. And number three, give you a highlight of our last symposium that we had a couple of years back. Okay, so just did these three things. So here we go. And we all know the San Joaquin Valley has a real shortage of health professionals, okay, compared to other parts of California and overall California, a huge shortage of healthcare professionals. And it's very evident from the next slide. You can see over here, we have about 92% of the population living in an area where there is a shortage of health professionals, right? So HPSA, health professional shortage areas, compared to 28% of people living in California. So like way bad. So, and if you compare physicians per 100,000 in Valley and overall in California, the average, in every category, we are lagging behind. Look at psychiatrists, like, almost half of what we have an average in California. So the situation is dark. So in that case, there's a huge potential for telemedicine, right? That we can think that it can bridge the gap. It can increase access with health information technology, video, audio, using a smartphone, tablets, computer. This can actually really help bridge the gap and increase access for everyone. However, this depends on access to broadband technology. Okay, so where do we stand on broadband? So the adoption of broadband has been going up from 67% to 85% in 2014 to 2021 data that we have. This is from USC study that they recently published in last year. And overall connectivity, like if you include the smartphones only, it's like way up, 91%. So it's pretty good, not that bad. But if we just look under the hood, like what do we find? There's an age divide. 7% of Californians age 65 plus, their access is 77%. And on top of that, we don't know like how savvy they are with using the technology, right? But still they have this access 77 compared to 85% overall connectivity in California. And those who are between the ages 50 and 64, there's 90% access and 95% for people between 18 and 49, of course. Okay, so there's age divide here. People with disabilities, they're way lower. Their access is 73% compared to 85% of Californians. Okay, so that's another problem. If you look at the racial divide, Hispanics have 76% connectivity compared to 85%. They're way lower. So other groups are doing better. And among the whites, 95% connectivity. Okay, so there's a clear racial divide. And we all know over here that we have a lot of Hispanic speaking like population, Latinx population that can benefit from telehealth, but are we able to capture their services? And Hispanics who only speak Spanish, among them, only 65% are connected, and 25% have no connection, and 10% rely only on smartphones. Okay, so it's another important racial divide. Is there a geographic divide? Apparently, no. I mean, like there is, but no. See, like LA County and Central Valley. LA is an urban area. Central Valley, rural area. Both like have 20% or 20% of people. There is no connection. Okay, so it's not a big deal. But if you look at this map, you can see over here the region A, the Central Valley, over here, and over here we have LA County. Bay Area is doing way better, right? Only 9% people don't have access to broadband. 91% they do have. So there's some divide, but purely rural, urban, don't think so. So what is the reason? What is the main key underlying factor? It's probably income. Okay, so people who are earning less than 20%, $20,000, among them only 70% has access. And people who are earning more than $60,000 or 99% access to broadband. So again, high income, easy access, low income, probably they don't have access to telehealth. So something to think about, like, when you're talking about access and whether telehealth can bridge the gap and bring in more people under the care. So now let's talk about telehealth use. So this is, again, USC study that came out last year. You can see overall, like half of the population, they did not ever use telehealth. Right? They didn't check, they didn't use smartphones or anything like that. And the rest half, among them, like 18% by phone, 19% by smartphone, and computer, like 14%. Okay? And then there is some racial divide. Whites have, they're faring much better. They use smartphone and also the computer, and you see the differences over here. But I wanted to like take a look at the Hispanic and non-Hispanic population divide. It's like quite stark. And I also want you to like look at this number over here. Hispanics, only 7% of are accessing by computer. And that's like broadband. And what could be the reason for that? Maybe they don't have computers, or maybe they're having difficulty, going to the websites, and maybe they're not bilingual, right? So we don't know that. So there's something to think about, like why are they less? Maybe they don't have access to broadband, as I mentioned before. So there is some racial divide when it comes to use telehealth services. So let me ask you a question, changing it here a little bit. Are you confident in the safeguards that are put in place to protect medical records from unauthorized viewing? Are you confident that they're like safeguards, like you feel confident, like if I put medical information? By show of hands, let's see, like I feel confident. I feel confident. Okay, I think I have 50%. And no confidence.
I'm naive.
All right. So that
So that you can be
I can
in the camera.
Oh, okay. So here's the survey that was done on all Americans. It's not California, it's like all. And people are confident. It's like 84%. Like this is 18 data. They're okay. They have no problems. They're fine. However, they're concerned when health information is electronically exchanged between providers. That's where they're like some concern. Like, okay, I think they're safe. They're put in a safe place, but when it goes from one doctor to another person to another person, then they're kind of concerned. Like, maybe it's not so safe and secure. Were people withholding information from healthcare provider due to privacy or security concerns? Well, not so much. They used to at 15%, but it's come down. It's been coming down. Okay, so that's pretty good. But what is happening in reality, that's a little bit of concern, is look at like 2015 onwards, like breaches of unsecured but protected health information. That has been going on. And it's very, very high, like almost like 100 million or 100 people, like breaches that individuals are affected by breaches. Okay, so that's something people need to be careful about, and something we need to talk about and concern about. Are the providers adopting telehealth? Of course, yes. From after the High-Tech Act was passed in 2009. And that provided incentives for the use of electronic health records among providers, it has really gone up significantly. You can see that like from like about 2010 around that time, like in the 25% to all the way to 90%, 89, 90%. So it's like way up. So adoption took place because of incentives and because of also penalties, right? So it works. This is like office-based physician, the same thing. It has gone up. This part over here shows people, the hospitals, the office-based adopting certified EHR. So not all EHRs, electronic health records, are certified. Okay, so certified EHRs have been going up also. Okay, so which is a good thing. So it's being used, doctors. Another interesting data I wanted to share with you is this is like physicians' hour worked by activity and years since graduation. So people, doctors who graduated like 1 to 10 years, and people who have been practicing like 50+ years. And this one, like the blue one, it shows like how many hours they have put in for telehealth purposes. And I did some ratios over here, and there is no, age divide. Like, it's not like younger people are spending more time in telehealth and relatively older, like practitioners who have been practicing for a long time, they're using less. No, I didn't see that. The overall 2.2, which is roughly about, I think like out of 34% of their patient care, I calculated like 6%, 6.5% of their time was on telehealth. Okay, that's something to look at. But it had been going up. Okay, so from 2015 to 2020, it went up by 22%. So from 1.8 to 2.2, so spending more hours. But again, this is pre-COVID. Okay, I'm expecting that it has gone up significantly after the COVID. So I'm curious to know like what the data look like in 2023, 2022, whether it's spiked and it's gone down or it's like remaining there. One other thing I wanted to like highlight is like, there's again, this is a survey. It shows that like 82% of people want at least 1 or 2 days to work from home. Okay, 50%, more than 50%, 3 to 4 days at least to work from home. So this is a national trend. I'm curious to know, like, is it the same among the physicians and the practitioners? How do they feel about that? Okay, and that will have repercussions on how we deal with medical care. Very quickly, like the findings from focus group from 2021, from 2 years back, what did we see? We found that like they're using, these are like people from the region. We invited them into the focus group discussions, and they mentioned they're using Zoom. This is like peak of COVID, okay? And it was a Zoom, not like in-person meeting. And they were using ClickSoft, WebEx, and Epic. They mentioned that many practitioners lack telehealth skills. HIPAA compliance was a big deal, big issue. Like they're somewhat confused about that. And they're also thinking about like, worried about etiquettes of online interaction with patients. Like, how do you talk about it? Do you ask more probing question? Is there privacy issues? Are people sitting around them? So that was like also something that they were worried about. The administrators, they had a steep learning curve in patient management, scheduling follow-up visits, billing and reimbursement, and interacting with off-site specialists. So my question, the final slide over here, like my question that you can think about. Does telehealth provide at least the same or better quality healthcare? We want to know that. Does telehealth improve access to healthcare for people with low income, disabilities, non-English speakers? Does telehealth foster stronger relationship between patients and care providers? Like when patient went to the doctor face to face, I can have a relationship, like shake hands or not shake hands, but eye contact. That kind of brings the patient and the doctor together and feel open instead of just talking over the phone, not seeing the patient or the doctor. So how do we measure the quality of care provided by telehealth? Okay, so that's something we think about. So probably more research is needed. That's all academicians say, right? More research is needed. So I really want to know, like, patient and provider satisfaction. Are the doctors happy doing that? Are the patients happy doing that? So I hope our panelists will talk about that. And that's it. Thank you so much.
Okay, now I would like to talk about Dean Schubert. She is a visionary leader who has the ability to make impactful changes. She's strong yet compassionate. Her passion for excellence has created a great environment within the college where we are supported to make some really bold moves. In addition, she is instrumental in building strong bridges of collaboration with our community partners. I still remember sharing my passion for telehealth education and training and see where we are today. And I want to make sure that, you get to meet her. So Dean Schubert. Yeah.
Oh, thank you. Thank you. Thank you. I just want to share a few words with you. Thank you so much, Dr. Hajela. I really admire your vision for bringing something to life. It was really fun to watch you get ready this evening, but to watch you over the last few weeks communicate your passion and share that and put a plan into action. And so this is very thoughtful. I'm excited to learn from you all this evening. The whole thing about telehealth, we've all come to appreciate it in different ways, in different places. And most recently, my experience with it was Dr. Ko gave a presentation at a meeting I was at about a project she's working on with pediatric physical therapy, helping to serve our rural communities where there are children that are not able to access physical therapy because there are no providers in the area. And when she presented, I thought, oh, I'm just going to see what she's doing. But she's studying what she's studying. She's being a real academic studying if her process of doing physical therapy via telehealth is making a difference. And she's using sort of a version of community health workers getting into the home who are able to provide the hands-on care because she can't be everywhere. Her teammates can't be everywhere. So we've got to find other ways. And I've been very inspired now that I saw that presentation to see when you talk about hybrid. Hybrid means lots of different things now. It's not just about me being on the screen with somebody. It could be me being on the screen, but somebody being physically present with someone else to be able to help move whatever that care is along in a way that's needed. So I feel really honored to get to learn from my colleagues about the things that they're doing that are making a difference. And I get inspired by the work that you all are doing and the changes you're making. We have visions for partnerships with India, and that would all be via computer. And I really appreciate that we're having the conversation about access, and that's critical. And we've got lots of partners in this community working on that, because if people don't have phones, video, other forms, certain kinds of telehealth cannot be presented this way. It needs to be visual. I could describe something, but we might end up with a very poor diagnosis. I wouldn't even want to do that for my dog. So, we have to think about what's real, but I just really admire my colleagues who are doing really important work. I think 5 years, 10 years ago, we wouldn't have thought physical therapy was one of those areas that we would have been doing through telemedicine, and yet we are changing people's lives. And so that's one example. And we're looking at the process behind the process, and that's really, really important for making a difference. So thank you for the opportunity to have a few words. Thank you to our panelists who are here for helping us grow our partnership and looking at how we can do this together, because some of the services we want to provide, we need teammates to be able to do that. And all of our students that are graduating from our clinical programs need hands-on telehealth experiences. And so we need each other to be able to move this forward. Shout out to Dr. Raymond and Dr. Hajela for your vision and for continuing to bring us together and have this conversation. So thank you very much. I really appreciate you.
Next, I would like to call Provost Hu in his role as the university's Chief Academic Officer. He's committed to empowering Central California's diverse students who will become the leaders of tomorrow. And I just want to say, it was so gracious of him to, accept this invitation. And I'm so glad that you came, Dr. Hu. Thank you.
Thank you so much. Good evening, everyone. Local health care leaders, experts, Fresno State colleagues. I'm very excited and honored to be invited here. I don't work in healthcare, but I know how important that is. We all need it. I'm one today. I had a video doctor's appointment with my family doctor, because I had pain on one side of my body. And that was in fact this morning and my first video doctor's appointment. Because I have been relatively healthy, I don't go to the doctors a lot. But the experience was very, very refreshing, very time-saving. It was also very convenient. So it gave me a lot of interesting thoughts and appreciation when I came to this event, this seminar. So I want to thank my colleagues in the College of Health and Human Services and thank the task force for organizing a telehealth meeting, especially thank Dr. Hajela for her great organizational capacity and put everything together. I know this is a very important topic, and in the last few years, the telehealth has gained a lot of inroads, mostly to serve the people. The traditional medical care has not served well for accessibility and affordability. But at the same time, to have a high-speed internet access, as we heard from the previous two presentations, also means that the population we wanted to serve probably are disadvantaged, even when we think about this innovative way of reaching out to patients. So I'm curious and excited to learn what this panel seminar could produce for the next step, for suggestions, ideas, innovative plans, so we can push it forward. Nowhere is better than Fresno State in the Central Valley to lead this, because we have the highest concentration of the highest educated health professionals. We have PhDs concentrated on this campus who care about the valley, the people, and their health, who are willing and eager to work with healthcare providers, leaders, experts in the field. And I also know, as illustrated today, our local healthcare leaders, experts are eager to work with the university to provide this service. So healthcare is not for you a business, it's a calling. It's almost like a mission. You want to do it because you care about people. I think that is most important when we think about the marriage, quote unquote, between technology, AI, and healthcare. But leading all of this is our genuine care and love to people who need healthcare, to people who have not had adequate healthcare. Again, I'm not expert in the field, but I firmly believe, as evidenced in the last 3 years of COVID, we were forced to think of different ways to deliver education in the last 3 years. Now we are not going to be forced to deliver healthcare, but we want to lead that movement and to be in control of it and to make the Central Valley a better place for our people, especially the historically, traditionally disadvantaged people. So thank you very much. I can't get it through video for the longest.
So now we'll get started the moment we were waiting for to get kind of welcome our keynote speaker, Dr. Ganga Hematillake. He's the President and Chief Medical Officer of United Physicians Network and Physician in Charge of Medical Education, United Health Centers. Dr. Hematillake has been involved in telehealth for nearly 20 years. And with excellent historical perspective as well as use of telehealth during the pandemic and then changing the landscape of telehealth as we move post-pandemic. His keynote presentation would be on evolution of telehealth, breaking the barriers, and what the future looks like. Welcome, Dr. Hematillake.
Thank you for the kind introduction. So I was fortunate enough to get involved in telehealth long before the private sector get into the telehealth, because I was working for the Department of Veterans Affairs. We were seeing military veterans, and the military was using telehealth for a very, very long time. In fact, telehealth is very old. It's nothing new. The reason the telehealth did not take off was there was the policy barriers to overcome, and also some reimbursement barriers. So it never took off until COVID. So this is how old telehealth is. If you define telehealth as using telecommunication technology to provide healthcare, either to diagnose, treat, or monitor patients or persons, that started very, very early with the invention of the electric communication telegraph in 1840. So they are centuries old. So who used this? Military, to communicate and identify the casualties, what's going on with the casualties, what kind of equipment they need to take out, whether it's an airplane or helicopter, whatever. So that was when the telehealth invented. So there is an area medical health service started in Australia, because Australia has very, very remote areas where there are no physicians, no healthcare available. So they use radio. With the invention of radio, they use a radio to identify the healthcare needs, and they dispatch either the medications, equipment to do procedures, or doctors themselves by airplane. So that's another way of using telehealth. Then came the television. So 1950s is where the video telehealth was born. In fact, 1959, they started providing psychiatric care by telehealth. So that's when the telebehavioral health was born. In 1967, there was a comprehensive telemedicine system was installed in the Boston airport, because the Boston hospital was, Mass General was further away. So anybody who comes in sick and landed in Boston will be taken into this triage place. They'll do the blood tests, the X-rays, EKGs, everything, and they'll be read by, real time, live video telehealth at the Boston Mass General Hospital. Imagine how old the technology is. Then the biggest boost for the telehealth came from NASA. When the space race developed between the US and the Soviet Union, everybody wants to put the man on the moon first. But before that, they had to put animals into the space and figure out what happened to them in the space. So they hooked up all kinds of electrical connections to these animals, monitor their heart rate, blood pressure, blood sugar, blood chemistry, everything. And they were all transmitted wirelessly by radio information to the centers to analyze. That's when the health monitoring developed. Well, a dozen years later, government decided to give that technology to the civilians. So they started funding research in health telemonitoring, basically. There were a lot of people living in these remote areas that could not access and they used these technology to monitor their health, and proved that this technology can be implemented in the civilian world. So these were 60s. Then happened the internet. That revolutionized the telehealth entirely, because now there is another medium that you can transmit information back and forth. Now, exponential development of the digital technology, digitalization, where the information can be packaged into zeros and ones and moved very fast. So you can move a lot of dense information. High definition pictures can be transmitted. High definition videos can be transmitted. And so the technology that is used for these transmissions became much, much more accessible. Well, initially you need, thick cables, fiber optics, and suddenly you've been able to send this via radio channels, and the Bluetooth and various other technologies developed. That really, really helped to take off the telehealth. So let me just introduce a few types of telehealth. The first type of telehealth is the remote patient monitoring. The gadget right that you see up on top, it's called Health Hero Health Buddy, made by Bosch. And I used that in 2011. This is for the patient's home monitoring. This device will, get the patient's blood pressure readings, heart rate readings, blood sugar readings, all those things into this box, input into this box, will transmit via radio to centralized monitoring station. And the registered nurses are monitoring all the data coming in. And this helped lot of prevention of a lot of unnecessary emergency room users and hospital admissions of these very chronically sick patients. In 2011, when I was working in the Kansas VA, we put over 1,000 patients on these devices. Anybody who is getting out of hospital will get a device at home. Anybody who is hitting more than 3 emergency room visits a year will have the device placed at home. And their healthcare is monitored. And whenever the things goes wrong, a doctor will intervene and take care of it. Heart failure readmission rates were very much decreased by using this technology. Then we have the store and forward technology, which is the basic technology of taking a picture or high definition image, transmitting it to a dermatologist to read for skin diseases, or to eye doctor to read the retinal imaging. Radiology, very, very old technology. You can, there are people reading X-rays from India, 2 decades ago, right? It's that simple. So that's telemedicine, basically. Then we have the voice-only telemedicine, which is basically using a telephone. That is the most primitive version of that. We had to use that during pandemic because of the barriers of not having the broadband, people not having the smartphones or computers. Voice and voice video telehealth, which is now widely accepted. Remote robotic telesurgery, which is up and coming, unbelievable technology, where you can get yourself operated by a surgeon who is across the other side of the world, if at all. Military is using this technology currently. Most of the battlefields, they do surgeries remotely. The technology is available. That became possible after the robotic surgery was invented, the Da Vinci system and how robots are used. When that technology developed, not because they want to do distant operations, but because people want to do minimally invasive operations. So they cut less. People get out of the hospital the same day because you have teeny little 2 holes, remove the gallbladder, and you go home the same day. That's how the robotic surgery developed. First robotic surgery was a gallbladder removal. But they realized, wow, if I can do that 5 feet away, and the patient is there and the doctor is 5 feet away, why not put the doctor 20 miles away or 200 miles away, 2,000 miles away? Well, it wasn't possible because the video communication has a small lag. It's not real time, even though you thought it was real time. There's a fraction of a second delay. So you have an artery here, you put your knife and you want to cut, but when you cut, artery is not there because that fraction of a second things move until the 5G technology developed, which does not have the lag. With the 5G transmission, now you can operate real time. So that's when the robotic surgery became important. Now here is how the robotic surgery is done. It's a Da Vinci machine where, basically a robot does the operation. Tele-ICU. I was involved in tele-ICU development in 2011 time. Most of the VA hospitals, we have 150 hospitals at the time, all had difficulties in getting intensivists to work 24/7 in the ICUs. So most have 1 shift with the intensivist, and the remaining 2 shifts of the day, they hand over the care to a centralized interventional services. We had 2 centers, one in Cleveland, one in Minnesota. They will take care of all 150 hospitals, basically. So they have interventionists like 15, 20 of them working in every night. And they have all connected, and they can monitor every single patient in every single bed. And if the nurse wants to talk to them, all they have to do is to push the red button, and on the TV, the doctor comes up, he can see the patient, and the doctor has full control of all the equipments, respirators and everything. He can change the parameters remotely. And patients are being cared by thousands of miles away. This was more than 10 years ago. VA was that advanced in doing it. I don't know when Kaiser started this. Kaiser started doing it. Yeah. No, I mean, tele ICU.
We have been doing it, yes.
Yeah. So same period of time.
Not 10 years, it's 3 years.
So the technology has so much developed right now since the telesurgery started. Now they have all these equipments, like they put gloves that have tactile sensation. When you feel, when you feel something, you actually can feel it. Like in your gloves, there's technology built in. So you have these 3D goggles that you use. You have the 3D image of the patient 100 miles away. And when you touch a nerve, you feel the consistency of the nerve in your fingers because the gloves have haptic sensory sensors built in. So we can actually feel someone else's organs hundreds of miles away. This picture is from 1925 Science and Invention magazine's cover. This tells you the imagination of our people. That long ago, they saw how telesurgery is done. Here's the surgeon moving some equipment, and the similar equipment is present at the patient end. These are connected by wires far away. And this picture is a depiction of telesurgery, 1925. Telephysical therapy, I don't have to talk about that. I mean, you guys are already doing that. We did telesurgery at VA in 2007. So I was in charge of telemedicine at the Fresno VA in 2007 through 2011. And we had a lot of spinal cord injury patients, and some patients live far away. And so they used to come to we have used special mode transportation in the gurneys. They were brought in to do physical therapy, 2 to 3 times a week. That journey causes many pressure ulcers and other morbidities. So what we did was we put the telemedicine, video telemedicine equipment in clinics because we needed a broadband, and most patients didn't have broadband then. But we put T1 lines into the clinics that we have. One clinic was in Oakhurst, and I used to work there 1 day a week. And we put broadband into that and put the video telehealth, and we'll bring the patient because they live in the same town. So it's easy to come to the clinic close by rather than coming all the way to Fresno. And we had high definition cameras. We can observe the wounds and do the wound care. And then the physical therapists will come in, and we have the telepresenters. Telepresenters are being taught how to, do the movement of the shoulders, arms, legs, do the electrical manipulation, things like that. And, they would do that in the clinic. So that's what this picture is from Oakhurst Clinic, 2007. This is the equipment we had. And this comes in a big cart. It costs about $30,000 then. And there's a derm camera, with a very high definition derm camera. You can actually take very detailed pictures of the skin, and especially when you're doing ulcers, you need to have like a depth of the ulcer. And then the dermatologist and the wound care people will, the other end, will evaluate the wound and tell the telepresenter what to do, basically, a nurse. The nurse will do the dressing based on the instructions that they get from the doctor. Same for the physical therapy. They would do the physical therapy the same way. So this is the health buddy that I talked about. In 2011, we used that to decrease hospital readmissions. This is 2011 to 2012, when I was chief of staff of the Kansas VA. Kansas VA and Kansas University partnered with the state of Kansas to put telehealth all over the Kansas. Kansas is a very, very large state. However, the cities are concentrated, and all the healthcare systems are concentrated in the cities. So we had like 2 cities, the Wichita, Kansas, and the Kansas City, and the Lawrence, where the KU was. That's where all the healthcare was. Everywhere else, there's no healthcare access. There's no doctors. There's like small dingy clinics. That's all they have. No specialist access at all. So what we did was we used VA resources, but we had several clinics all over. We put telehealth equipment in all those locations. We also put telehealth equipment in churches and various other organizations where they could have broadband access. State helped with the broadband access through grants. And what KU did was to provide the subspecialists. So the KU has a huge subspecialist network. So the cardiologists, pulmonologists, rheumatologists, all were able to tap into the system and provide care to patients who are living 400, 500 miles away. And they will bring them in whenever they need to come in. But most of the time, they doesn't have to come in. These can be done remotely, and prescription can be sent electronically, and they can be taken care of. So this was a huge success of partnership, something that maybe Fresno State can envision to work with city, county, healthcare centers like us, hospital systems, medical schools. They all can partner together. So COVID and telehealth surge. Now, there is a silver lining in COVID. That's where the boost for telehealth came, because of the necessity. Until then, there were barriers after barriers after barriers to do telehealth. Medicare would not pay for telehealth until then. So no insurance company would pay for Medicare telehealth visits. So why would the doctors do that if you're not getting paid for that, right? So they didn't do that. Then hit the COVID, everybody realized business is over. We had to do things differently. So I was sitting in my department. I was a deputy chief medical officer, and my chief medical officer here at the United Health Centers, and CEO all sat in the table, said we have to close down all our clinics. There's no way, because none of our doctors want to come to work. Okay, they are so scared of getting exposed to COVID. They don't want to see patients. If they want to see patients, they want to dress up like going to the moon. And this is impossible. So we said, okay, there's a way out of this. Let's do everything by tele. And nobody knew what telemedicine was, because we were doing zero telemedicine, in our clinic. So we immediately turned to telephone, because we didn't have any way of doing this video. So everything became telephonic care. So all the patients were still seen. Our providers see about 20, 30 patients a day, and we still see 20, 30 patients a day, but by telephone. We have the access to their medical records. We call them up. We see what's going on, check their blood pressure, blood sugar, change the medications if needed. Everything went by remote. Then after a few months, we learned about the video technologies. Doxy may become available to us. So now we can actually see the patient and take care of them. So then becomes video. So 95 to 99% of the care provided by United Health Centers in the Fresno County and Tulare and Kings were provided by tele for almost 2 years. We have 180,000 patients. That number increased to 200,000 during the COVID time, because we did a lot of testing and treating, partnering with the Fresno County. And that time we have provided over 1 million telehealth encounters, 1 million telehealth encounters. So much of benefit from using the technology. And what was the outcome? Did we kill anybody? Did patients' quality of care change? No. Okay. Patients were happy. I have patients who are farmers who just work in the farm, and they could just take a 15-minute break and answer the phone and take care of the business. Otherwise, they had to take a whole day off to come to the clinic. And sometimes they paid laborers, and they don't get paid if they don't go to work. So this is an enormous benefit. That's why we started fighting with the state when they wanted to go back to what it was at the end of the pandemic, right? So the legislation changed right now. It's going on, and I'm a member of the California Primary Care Association Telehealth Taskforce. We advocate the legislatures to keep the benefits intact, like we used to have during pandemic, because we want this to continue. We want these services delivered in many different ways. But only way we can succeed is if the reimbursement. Here's another interesting thing. We have dental service. We have more than 20 dental clinics all over town, right? We had to close them down because they are the most exposed. Somebody's opening their mouth and waiting in front of you, right? We don't know whether the patient has COVID or not. There were no testing available at the time also. We closed all dental services for 3 months, but then we restarted doing this. It's called teledentistry. So now patient can use the iPhone camera and open their mouth, and dentist will see what's going on. And if it is something, like a big cavity or something something like that, they will bring them in. Otherwise, they will use some antibiotics to calm it down and somehow buy time. So it's very interesting. Now, actually, it's mainstream. Now they have cameras in a probe that they give it to the patient, battery operated, and you can put that into your mouth, and this high definition picture comes up on the dentist office. So patients can be seen from home. So again, we needed a global pandemic to break the barriers. The barriers were that much hard, but we did break the barriers, but now we need to keep the barriers away. So that's what we all need to do together. We have to partner with the state agencies, partner with the universities, partner with the medical schools to let the people who are making the regulations know that this is a life-saving technology. This brings the access to the community. And some of those numbers would be mind-boggling. Let's see. Prior to the pandemic, only 1% of the Medicare services were provided through tele. Okay. During and after the pandemic, 32% of the Medicare claims in April 2020 were telehealth visits. If you look at the disparities here, I think I have another slide somewhere. There were no changes in quality, I said. About the population who took, here it is. Among the Medicare users, okay, the Black Medicare users have 58% of them have at least one telehealth visit during the COVID period. Hispanic Medicare users have 64% of them had at least one telehealth visit during this period. And white patients, 51%. So everybody's more than 50%. That tells you the access to care. Or also, if you look at it, a lot of rural patients who would not have got access to care did get access to care because now they were available to see the doctor by tele. So training, we used to train bedside manners in the medical school. Now they need to teach website manners. So medical schools haven't started teaching telehealth yet, though, unfortunately. Their curriculum does not have telehealth. That is something they need to now start doing. How to care remotely, how to provide care remotely. Just for food for thought.
Yes, please have a seat here. We include you in the panel. We have so much to learn from you.
I'll pass on the gallbladder.
Okay, so we'll get started with our panel discussion. The way I would like to do is I'll call your name, I'll tell who you are, and you are a star in your own right. So please come and have a seat. There are names for everyone, and then we'll get started. Our first panelist after Dr. Hematillake is Dr. Marina Reutemann. She is the president of Fresno Madera Medical Society. She's a health science clinical professor at UCSF. She's also a hepatology fellowship program director. She's a board certified in internal medicine and fellowship trained in medical education. She is a member of the American Association of Study of Liver Disease and an elected fellow of American College of Physicians. I know that her hobbies are yoga and reading and creative writing. She is fluent in Russian, so welcome. I also wanted to add that, Marina was so instrumental and helpful through Fresno Madera Medical Society for, helping me reach out to such esteemed panelists. So I wanted to extend my gratitude for doing that. Our next panelist is Dr. Joel Brownell from Valley Children's. Dr. Brownell is a general pediatrician who has been in the Valley and with Valley Children's Healthcare since 2000. In addition to his clinical work in the Charlie Mitchell Complex Care Clinic, he serves both as the organization's Chief Medical Information Officer and as the medical director of their primary care network. And he is a proud Clovis High School graduate. Our next panelist is Dr. Amit Saini from Kaiser Permanente Fresno Medical Center. He's a doctor trained in internal medicine and geriatric medicine. He received his medical degree from Delhi University College of Medical Sciences and has been in the practice for more than 20 years. He practiced in various settings, included office-based primary care, hospital medicine, and skilled nursing facility over 20 years. He plays tennis 4 to 5 times a week early in the morning. An interesting, I would say, insight is that we both are from Delhi, India, so that kind of, there is a connection there. Our next panelist, last but not least, is Mr. Joe Prado. He is the Assistant Director of Fresno County's Department of Public Health. In his 24-year career with Fresno County, he has had the opportunity to work in multiple departments. Mr. Joe currently is the Fresno County representative on the Central Valley Health Information Exchange, which covers 4 counties in the Central Valley, exchanging health information from major hospitals and local clinics. He is Bachelor's of Art degree from CSU Fresno in psychology, so he's an alumni. Yes, I think I will be. So we were told we have to share mics, so we will do that. So we can share mics. So the way we do this panel is try to kind of make sure that we can cover different aspects and expertise. So what we'll do is our first theme is about the application of telehealth. So we will go through the panel, and I'll start with Dr. Joel Brownell talking about his experience with telehealth and how he has overcome some of the challenges.
Great. Thank you. I'm really happy to be here this evening. One of the questions that was posed earlier is telehealth as good as in-person care? My career has somehow evolved into technology. I'm our Chief Medical Information Officer, and so I spend most of my time working in this arena. And my short answer is no. I don't think virtual visits, telehealth, are as good or have as much quality as an in-person visit. I think going on a date with my wife virtually in the metaverse is much less ideal than being in person. So I think the question perhaps should not be whether or not virtual visits, virtual meetings, metaverse is better than in person, but perhaps given the realities and complexities of life in general, the question becomes where and how do we weave remote work into our daily lives? And in this case, healthcare. And I think there's a real opportunity there. We heard about the history. It's been many decades that we have been toying with some of these technologies, and the pandemic supercharged that. Depending on who you talk to, you'll get hyperbole that says something like, we advanced 10 years in about 2 weeks. I talked to my peers across the state, in particular in pediatric healthcare, and when we removed the policy barriers and the financial barriers, it was phenomenal how quickly things would change. It wasn't all clean and smooth. We did it really rapidly, and it was messy, and it wasn't as well planned out as it might ideally be, but we showed that we could do it, and we showed that there was real value there. The volume of virtual visits skyrocketed It stayed high for some period of months. Certainly the first year or so, it's tapered off. The data that I'm looking at this point for Valley Children's in particular, I think is representative probably of the national sample, and it's dropped quite a bit. My clinic work is in primary care, and so I do these visits with my own patients, and I also try and help guide our organization in terms of where do we find the value for this. And I'm convinced there's a substantial portion of patient care, depending on your specialty, that can really be value add. It's better if I can see my patient in person. But what if my patient is an adolescent who's wheelchair bound and lives with a family member on the second floor of an apartment with no elevator? It is nice to see them in person, but that's a huge barrier and a huge burden. And there's a lot of examples of ways that I think we can blend virtual and in-person care over time to really optimize the experience for the patient and families in particular, and still meeting the quality and efficiency needs that we need within healthcare. But I think it's going to take some time to sort out where that sweet spot is and how we really assess where we're maintaining value and safety versus we may be missing the mark, but we just don't know it yet.
Thank you, Dr. Ram. Dr. Rothman.
Hi, everyone. Thanks for having me. So telehealth and hepatology. So hepatology is a study of liver disease, has been around for a really long time. So back in the day, before we had these amazing treatments for hepatitis C, treatment for hepatitis C was really, really hard. Patients got really sick. Nobody wanted to treat these patients. It was really complicated. So we had what's called an ECHO program. And an ECHO program basically was like classes for doctors. So once a week or once every couple of weeks or once a month, a bunch of doctors would get together and they would bring their patient cases. And there would be an anchor or an expert or a specialist in charge of this group, and the doctors would present the cases and the expert would tell them how to do it. Then they would go out and provide this much needed hepatitis C care to the patients. So this has really been like 20 years in the making. So we've had a lot of experience with it in real life. And when the pandemic hit, suddenly it became very, very popular, which is great. But I just want to say that at least in our field, we've been doing it for a little while. Now, do I love telehealth? I'd be really honest with you. No, I do not love it every single day of my life. It certainly is incredibly helpful in some fields, right? In hepatitis C, it's amazing. And in hepatitis C, I can treat patients and I can teach people remotely. And I think this is just as good. In other aspects of it, it is nowhere just as good. I was sharing with a panelist earlier today that a lot of the times the patients come to my office and I examine them because that's what I do. I'm old. Patients would tell me, like, Dr. Broidman, nobody has ever touched me in like 5 years. Like that seems really abnormal to me, because I think a lot of my relationship with the patients is, to touch and to talk and, to really experience them in a very special and sacred way that we learn how to do in medical school. I can certainly see the value of mixing the two, like you said, right? I think there's a value of maybe seeing your patients, once or twice a year and doing some virtual visits in between, but it cannot replace, the in-person care entirely. So that's been my experience. I don't want to take all the time.
I think we can share that. Dr. Singh.
Thank you so much. And thank you so much for having me. I'm learning a lot, and right from the history to learning from my colleagues' experience in Nupur. Thank you so much for sharing what you're doing. Before I come to my passion, I would say that one of the healthcare disparity that we have is serving those folks who do not have access to care in our rural community. It's for me, it's unimaginable because I work in Kaiser Permanente. Folks have already access to insurance, and they reach out to us and we provide care for them. It's difficult to imagine when someone do not have access to care and where to go. So that's where it's incredible work that you're doing. When I started to practice, I firmly believe in building a patient-centric model of care, where the care system is around patients. And this model of care provide different level of care. When someone called me for telemedicine, there's a reason to call, right? COVID, I have cough, I have shortness of breath, I'm having fever, I have a rash. That's the reason for them to contact me. And as a physician and my team have an opportunity at that time to do a healthcare assessment. Well, you're 45 years old. When was the last time you had a blood pressure check? What medications are you taking? Have you had your vaccines taken? Are your allergies updated, right? Have you had your cholesterol checked? What is your family history? And that's where you need an integrated medical record, not just in one system, but systems should be able to share those medical records. So if there was someone who's prior receiving care somewhere, I don't have to duplicate the test. I can check and just simply update them in the system. And that's where I feel the telehealth can potentially be way more powerful. That's one. Two, why would my patient listen to me when they're only hearing a voice? Why would a patient listen to a doctor? Because they trust, right? It's not my degree. They trust in me, not because of my degree, because they have met with me. I have examined them and we have built trust over a period of time. Telehealth alone is inadequate to build that trust, especially when they're connecting with different healthcare providers at different time. So a consistent provider over time. And again, using telemedicine with office-based medicine, building that trust is critical. Last piece I'll state, because I think I'm slightly unique in practice, probably a little crooked-headed. I work in office, hospital, and nursing home. Imagine telemedicine in nursing home, right? Because my patients, who are you? Well, I'm Dr. Saini. Oh yeah, I know you. I saw you, right? So during the time of COVID, we did go to many nursing homes. We tested our patients, but some nursing homes were shut down and we were not allowed in. And anytime you have to go inside a nursing home, you have to dress up like in spacesuit. It's going to take time. And for us to visit many places was very difficult. So at that time, we invested in a device called TytoCare. So I'll describe the device to you. Imagine an iPad on a cart, and that is used by the nurses. So my patients don't have to manage it. The nurses bring it to the patient, and patients have a good iPad-sized monitor in front of them that project a little higher volume, and I get a computer screen to see them. Now, on top of that device, it has a stethoscope, so I can listen to their heart and lungs. It also has a camera where I can check their skin, rash, and take pictures. It has an otoscope where the nurses can place the probe in the ear or nose so I can have their ear and nose exam. And it has a tongue depressor with the camera so I can check the throat exam. That was breakthrough because now I'm going through getting a lot of critical information I needed and enhance my visit. Yet, in practical experience, it did not beat when I was in front of them and connecting with them.
Hello, everybody. Just thank you so much for the invitation today and just being part of the esteemed colleagues here. Just really grateful for this opportunity. I want to give you a little bit of a public health perspective here and kind of what the Fresno County Public Health Department really leaned into telehealth. It goes back to 2016. We have a tuberculosis clinic where we treat patients for tuberculosis. And what we do is we do directly observed therapy. That means we watch you take your medicine. We physically will drive to your home, to your work, and we will watch you take your medicine every day of the week. Why do we do that? Oh my gosh, that is so labor intensive. Well, we want to make sure you complete your treatment protocol and taking that medicine so we don't develop multi-drug resistant tuberculosis, which is an entirely different type of treatment that you would need to do with the patient. And just to give you an example, somebody with tuberculosis, the first line drugs cost roughly about $200 a month. If you get multi-drug resistant tuberculosis, that can go anywhere from $10,000 to $40,000 a month. So it's a significant difference. Second line drugs also for TB, it really wears a lot on the patient. You're talking new diagnostic tests. So it really is something for the patients to be able to do that. That's why we do directly observed therapy. So think about that. We're driving everywhere every day. So what we did is we went and invested in asynchronous video. So that is pretty much somebody downloaded an app on their phone. They take their medicine while they're with their phone, and we're able to check it throughout the day. And then we count them yes for that there. When we talk to our patients, they said, I'm sick and tired of seeing you at my work. It's embarrassing. You're at my house. My neighbors are wondering why the county vehicle is out there. This is a bit ridiculous. So can you please stop? And so we listened to our patients and said, okay, let's do something a little different. And what we found out after the first year, our adherence rate for tuberculosis was previously around 30 to 40%. It went up to 90% in active TB patients and 80% in latent tuberculosis patients. Significant increase. Our patients were a lot happier overall, like I don't have to see you every day. But then the cost savings, then we saw the cost savings of over $100,000 benefit to the department on just that one piece there. We took that money and we started investing in different types of TB treatment and also use that money towards investing in syphilis medication as well. We reinvested back in our community with those savings as well. But there was something we didn't know. There was an offshoot of the benefit of this. We reduced our carbon footprint. So when we started going through the analysis, we said, okay, so we're not driving hundreds of thousands of miles a year. What does that mean to greenhouse gas emissions that we have in our vehicles? So we partnered with Air Resources Control Board and started to calculate that. Here's the model year of the vehicle. Here's the emissions rate. And they did a calculation. They said, wow. Basically, after 1 year, you took over 8 vehicles off the road by doing telehealth. That was astounding. Did not know. And it's something to 41 metric tons of CO2 we were able to reduce. So telehealth, great for the patients, great for our nursing staff and being able to manage more cases as well. But also your carbon footprint, you're able to reduce that. And so as we think about telehealth, let's start calculating and gathering that data on how much we're reducing the travels, vehicle miles traveled. And that's important as every transportation agency in California, in the United States, has to calculate, how are you going to reduce your PM 2.5 particulate matter? How will you do that? Telehealth is part of the solution. And I love the comment about part. Telehealth is not the whole solution, but this is how we can start thinking about not just the patients we serve, but the community overall and really improving air quality as well.
Dr. Ganga?
Okay, so you probably know by now that I'm a strong proponent of telehealth. By the way, that photograph of Oak Health Clinic in 2007, that had an otoscope, that had a stethoscope, that has a high definition camera, all equipments in there. You can do a full physical exam using that equipment, 2007. It is now available in Tito Care, which is much more sophisticated now, wireless technology is used between the peripherals. So he plays tennis a couple of hours a day. I see patients via telemedicine all over the country, a couple of hours a day for fun. 6 o'clock in the morning in California is 9 o'clock in Florida. That's the time they come on. And I can see them from California. So yeah, for fun, I work for a company called American Well. Can you see a board certified doctor 4 o'clock in the morning? Suppose I'm asking my female, let's say, if you have fever and burning pain when you pee and you know you have a UTI and you're going to need antibiotics, 4 o'clock in the morning, can you see a doctor? If you want to see a doctor, download mwell.com app, register yourself, put your insurance information. You see a board certified doctor 24/7 anytime you want. They will come on, they will evaluate you.
No, I think that's really good to hear. And I think if I have to, summarize of what I heard as a different perspective from everyone, I will bring on my neuroscientist cap. I want to think about the brain and, brain when neuroplasticity happens, it is very messy to begin with. And, that's what happens, when you start something, it will be messy and there will be disparities in how we will kind of project things. But I think that's where the standardization comes in. That's where, you have to call up the policies come in, and that's where you have to say, it works for this. I have seen it. Let's kind of move forward. It doesn't work for this. Let's not keep burning, ourselves, and let's not put our forces behind it. So we have to be strategic about it. I think that's the theme that I'm hearing from the panel and that's what I think I want to, channel here is that, it is not, like I said in the beginning, it's not going to ever replace in-person care. But what it can do is, like how Dr. Ganga said, that, if you need care and if it is urgent, how you want to make it more accessible. I think that's what I'm hearing today. So I want to move on to, the next part of our discussion. It's about, we did talk about how you can have the stethoscope, how you can have, various technologies. So I want to talk about the scope of innovation and collaboration that, you foresee through, the task that you have already done. So I will, I'll start with Marina, and, we can start from there. Any type of, what are the things that you're hearing or listening, that you have gone to different conferences that you saw that were eye-catching, and you thought, that we can bring back to the Central Valley?
Absolutely. I'm gonna take a slightly unorthodox approach to the question. And I think it's wonderful that one can see a doctor at 4 o'clock in the morning. Do you know what is required for that to happen? Any takers? It's not a technology. What's that?
So legislation.
No. It actually requires a doctor, right? There has to be a doctor available to see you. And it doesn't matter how much technology we all have. It doesn't matter how many fancy devices we have. If there is not a doctor on the other side of the line, you are not going to see one. So to me, the key is really training doctors, right? And this is what we do downtown at UCSF Fresno, is we train new doctors. And this is really my passion. This is what I love doing. And I really, really, really want to continue being able to provide that resource to our community, because our community is unique. Seeing a doctor from San Francisco is different, because the doctor from San Francisco doesn't understand that, you're a farm worker and you've taken a day off to do it. And it doesn't, your doctor doesn't understand that the reason you're not going to AA is because you don't have access to AA, you don't speak English. There's so many unique characteristics to our population and to the people that we serve in the Central Valley. So again, to repeat myself, I think the most valuable innovation resource is training new doctors.
Thank you. Dr. Hansani.
So I'll share with you an innovative program that I'm very proud of and I'm very passionate about. I'm very passionate about healthcare to the folks who do not have access to healthcare. So when someone is at nursing home and it's 9 o'clock and they have symptoms of UTI or they need a pain medication, what happens then? A lot of time the doctors are not there and the nurses have nowhere to go. And if the symptoms are bad, what are the choices they have? Suck it up or go to emergency room, right? So here we have used telehealth across entire North California, and we have solved the situation with the doctor's availability too. So one thing about access or healthcare availability is it is consistently inconsistent. It's never consistent. Monday is going to be 5, Saturday is going to be 12. You don't know how many. So you work on averages and then you supply with it. So what we did was we estimated all the nursing homes we have in entire North California. We looked at the average number of calls at night, Saturday, Sunday, weekends, and we created a team. And this team is with the nurses who are registered nurses certified. We created a call center. And we shared all the patients who are across North California in different nursing homes that if something happens, you have this phone number to contact this team. And this call center is now connected with one doctor across North California. I do that call. And 12 hours, a doctor would not do it. So we do 4-hour shift. So I could do 12 to 4, 4 to 8, or 6 to 12-hour shift. And I get written messages. So now I'm giving you a different platform of telemedicine, which is e-medicine, where I'm getting a full chart of the patient with the clinical question. And here I have patients' questions, I have their medications, I have their vitals, and I have access to their hospital records and what happened and what is the reason for them in the nursing home. Furthermore, I also have their life care planning, whether they like to do everything possible or they like to receive comfort-based care, and that helped me make a decision. If I have a question, I can go back to the team, or I have phone number for the nursing home to call. We are running this program for now over 5-6 years, and it has helped in providing good care at the time someone needs. One more thing. So a lot of time when you're prescribing medications like restricted medications like morphine or pain medicine, nursing home pharmacy don't have it, and regular pharmacy will not dispense until they have a doctor's prescription. So we use a prescription called SureScript, which is electronic through computer, and we have the pharmacy's number, and I can transmit my prescription to the nursing home pharmacy in the moment. And my patients are able to get the medications as needed. We have recently expanded this program to hospice patients, and we are serving them also now.
Great, thank you.
The perspective I like to take with the collaboration and different applications. What we learned from our TB clinic experience is that our patients did have smartphones, and this was our new immigrants coming into the United States, and they actually had a smartphone. When we went into the COVID response, and you remember my turn, how to sign up for a COVID vaccine. What we learned during the TB is that you have to spend time with the patients to teach them how to use the app, how to go through the different screens and everything else. So when we did the COVID response, our community health workers, we had 22 community-based organizations. We had over 130 community health workers going out to the community in our disadvantaged areas to teach them how to use My Turn, how to download the app, to do all those pieces. So telehealth will need a health literacy component. Our community, we need to really support them and educating them how to access the healthcare system. Now with the Affordable Care Act approved, there's 90% of individuals in Fresno County have health insurance. Do we see them accessing healthcare? No, not necessarily. It's complicated. Think about how long it takes for you to get your annual physical, and the wait time for that. There's a health literacy component that I think we have learned through the COVID response that we need to support our community in that way. And it is manageable, it is doable, but we have to be focused and intentional with our funding sources to be really teach our community what does it look like to the healthcare system. So great, I have insurance, I'm going to go to the ER for my pain in the belly. No, we don't want them doing that. We want to set them up with the primary care physician. And so I think that's going to be a focus. And then just lastly, in the rural areas, as you saw the chart with connectedness, there's broadband connection, but then there's also is the type of speed connection as well. As you kind of see, the videos are a little slower if you're not in a good connection. That's something Fresno County has a digital equity committee that is looking at where the slow spots are. And then as you dive deeper into the speed connection, you're seeing in the disadvantaged neighborhoods, they have lower speeds than in a higher area. So that is something that this digital equity committee is really looking at. How do we build that infrastructure? And there's been some great projects with Fresno Unified, really building that speed around Fresno Unified schools because of that. And then looking in the rural areas, increasing broadband, but also speed as well. And that is something that will work collaboratively with farmers out in the areas, in the rural areas. They want broadband out there too. And there's new federal dollars coming in. And so Fresno County is going to be working with the state and the feds to really build out that broadband connection, but also increase the speed within the metropolitan areas.
Particular thing that you like to hear?
Pardon?
Well, any particular question that you have?
No, I think my question was around, the scope of innovation and, collaboration that you think that you have seen somewhere else. Or, I mean, in your case, you're seeing right there in your department, but that you would like to talk about that we can, simulate.
Yeah, definitely. The collaboration is the way to go to expand the telemedicine facilities. Just like, for example, just like we did in Kansas, we have a primary care network, UHC United Health Centers. We serve 108,000 patients with 32 health centers. We provide primary care. Now we can access specialty care by telemedicine from UCSF or what other organizations have the subspecialists working. Partnerships like this could bring care where they belong. These patients live in Huron, 1.5 to 2 hours drive from Fresno. They can't come to see the cardiologist or pulmonologist. Maybe they can come once. And how about the 3 or 4 follow-up visits can be done by telemedicine? Maybe they can come to one of our clinics if they don't have broadband. We have broadband in our clinics, and they can see the subspecialists. Those are the partnerships we can think of. We can do that with the schools. If your students want to access care, can they access from university without even leaving the campus? That's possible, right? So we can do that. Do the medical students want to learn how to practice telemedicine? They can come to our centers and they can see how the telepsychiatry is done, how the telespecialty care is done. There are opportunities to learn from practicums. So yeah, there are many things that we can do by cooperating with each other, partnering with each other. Right now, I agree, we are in silos. Everyone is doing it on their own, but we're not talking to each other.
So I was going to deviate from the question and just say Chat GPT to get that out there first. It's innovation and it's healthcare, but I'm going to backpedal from that for the moment. We might come back to that. Mr. Prado and I have been involved with a large group with the Central Valley Health Information Exchange. He had mentioned his formal role with that. This is an example of collaboration, really just for the sake of patients being at the center of care that's been in place for well over a decade. Some of the technology that's not cutting edge, health information exchange, HL7 feeds, we're supposed to be able to share information within healthcare entities. The federal government spent somewhere around $80 billion during the middle of during the last decade or so to get the healthcare entities up to that penetration of technology that was shown there. And the expectation now is that that information can be shared and that it doesn't become proprietary either for the healthcare systems for their own business advantage or for the EMR companies who may have a competitive advantage they'd like to maintain by interfering with the sharing of information. So the federal government's made it very clear most recently with the 21st Century Cures Act that there's an expectation that information can be shared. But despite healthcare systems and hospitals making up much of the Central California area, really being at the table and working very hard to share information, I would suggest we had very limited success during that time period, unfortunately. And one of the major components of that is the technology, the different EMR capabilities, the lack of standards. And despite everyone wanting to do it, we really have struggled to get meaningful use from sharing that information. Some of the best ability to do that is if you happen to be within a single EMR. One of the medical record systems really so far does it better than others. And there's a big push to improve that, but we're not there yet. So this notion of continuing, I think, the regional collaboration, because healthcare largely is regional. And it is great to be able to do things when you're visiting your family member across the country or to see a doctor across the country for convenience. But the bulk of healthcare is really local. And so it's collaborations like this with an entity that doesn't necessarily have a business motive and can come in and help coordinate multiple other groups, because the healthcare systems really are interested in doing what's right for the patient. We really do believe that patients should be at the center of care. And I think collaborations like this would give us another opportunity both to help solve the challenges that we have currently, and perhaps even more importantly is to engage the generation coming up professionally to be prepared to help shepherd things along in the years to come, because there's a lot of good work to be done.
So, I think what we say is like, if you really want something, the universe is listening, and, the universe was listening because, I just so happened to, invite each one of them, and they just so said yes. And this is such a great panel because, we have people who are enthusiastic about it, people who are like, okay, hold on, what do we need to do? What are the right things to do? What are the right things to do now? And, that is what I'm hearing in the common themes. And what I'm hearing is also the pilot programs that you may have, experienced that you thought, were successful, or that you thought that can be simulated. So, being a very action-oriented person, I'm going to channel that and, bring everyone on board and to make sure that, these are not conversations, but we are taking a step further. When we say collaboration, what are the pilot programs that we are putting in together? Beautiful ideas about, what we are doing at Fresno State is, educating students, and those students become the pipeline task force in the Valley. And we know that there are shortages of, healthcare providers in the Valley that, we have to provide. So I think the innovation is the key, but, the human touch remains at the core of it. That's what I'm hearing from all of you through your experiences. So, that is something that I would, like to take forward. So instead of me asking questions, I want to pose it to the audience if they have any questions, and we give any questions. Yes. Please tell your name and
Yeah, so I'm Chiu, I'm a professor here. So I would say this symposium is such a success, and I do have a question about telehealth. That is, like, I know Medicare is covering telehealth, and so most of the older adults, they're covered by Medicare. And digital literacy is always a thing, and older adults, they may not so proficient in using those handheld devices. And just like Dr. Barolo said, we have to send out like the health social workers to be there, help them. So like in this Valley, can we really, like, what is the percentage we can actually cover those older adults who are not like proficiently using their devices?
Yeah, I think there's an opportunity here. So the state of California just has approved CalAIM, and it's a new reimbursement for community health workers that has never been on the table before. We built this. We built a community health worker network with COVID dollars, and we've seen this in place in September based on an evidence-based model, and we are already seeing the outcomes, and it is significantly positive. And we're waiting for the CalAIM reimbursements, because now that's another future funding stream to be able to sustain this community health worker workforce. So I think that is some of the funding. It won't cover all the costs, because we all know Medi-Cal doesn't cover 100% of your costs, but that could definitely support some of that there. But then again, we have to really focus in on what does digital literacy look like. Like the doctors have said, there's different EMR platforms. If we could standardize some of that language, what does that look like? It would help our literacy here in the Valley. If there's like very commonality in how we engage with our health records would be really helpful. But at least the community health worker model, we see some sustainability in the future.
Can I add to that?
Yes.
One of the things that we struggled with early in the COVID pandemic is the health literacy. A lot of our patients are older, not able to use the technology and whatnot. So we talked briefly about potentially engaging college students or high school students in teaching health literacy. I mean, that idea quickly got bogged down in COVID regulations and infection control and whatnot. But what if we picked it up now? Like, what if we, not just relied on, the literacy workers, but we engaged the entire Fresno State, or we engaged, Fresno Unified, right? I think that would be so much fun and so exciting, and it would just like expand our workforce dramatically.
Yeah, I think that's a great idea. Yes.
One more question. So Dr. Barolo, you said about reimbursements, and that reminds me, I remember Dr. Redman said we're training like new doctors, we're like training healthcare providers. So I'm just trying to get like, what is the reimbursement rates for like telehealth visits and in-person visits? Because if there is like a significant difference between the in-person and telehealth visits, then the doctor would naturally like go with the in-person choice, and that would limit the options for telehealth.
Anyone want to get that quick?
Well, so far, the Medicare and Medi-Cal both pays the tele-visit is the same rate as the in-person visit. There are legal challenges. There's fight going between the state and the payers, but we are doing everything to make the legislature aware to preserve the payment structure for the telehealth, because we know exactly what will happen if it is dropped by 50%. Then the providers will not have no incentive to provide telehealth. They will bring all their patients in person.
So with the pandemic at Kaiser Permanente, we actually have a position called virtuologist. This person will provide total virtual care. the difference is in pay incentive. The virtuologist pay is slightly lower than the primary care panel caring physician because this person is providing office space and virtual care with both. So that's.
Yes. Yes, please tell your name.
My name is Robert Mitchell, and thank you all for participating, giving us a lot of information. One of the things, I come from a community, West Fresno, grew up in West Fresno, still live in West Fresno. One of the things someone mentioned, barriers and things like that with telehealth, and as we as physicians understand relationships have to be built with patients. I just see that from in my community, and there was some number, I think it was 68% African Americans. That's not happening in my community. I'm just saying that that number is not accurate for my community. So as this train gets going and gets speed and moves ahead, there's going to be a group left behind. So my question is, what's the troubleshooting for that? You know, is there going to be a model built in to reach back and lift up as this train is moving?
Can I answer? Yes. I think that's the fundamental question. And the answer is in choice. Our patients should have a choice, how they like to be seen and where they like to be seen. And that is how we have built our care availability model. We actually stopped calling access word because it was giving stress to the doctors because it's a number, right? So we moved it from access to care availability. And when we built the model, what we did was in the physician appointment availability, we created all the slot as same amount of time. If I give telephone appointment, it's 20 minutes. If I do video visit, it's 20 minutes. If I see a person, it's 20 minutes. So the incentive is neutralized. Now it's my patient's choice how they like to be seen. And that's how we are working through.
To answer your question, probably is an image care that a lot of people don't know that they have access to telehealth. If you have Medicaid, majority of the people, even poor people, have Medicaid thanks to the Obamacare. You will be part of the Medicaid managed care that you will belong to either Calviva or Anthem Blue Cross, whatever the managed care company that provide care to you, and we are one of them. And they will have a card that the insurance card they have from the Anthem or Calviva. If you look at the back of the card, there is information of how to access telehealth in case of, if you have urgent care. There's either 1-800 number or a web link. And a lot of people don't know that this exists. They would go to the emergency room rather than calling that number and get a doctor by tele. So it is educating these patients who are out there that you have access. You just don't know how to access. That is the problem.
I think even this as a follow-up, I think, and I probably didn't articulate this well. I see there being a problem, even if greater numbers of individuals access telehealth for a crisis reason or something like that, that there are going to be barriers to building relationships through telehealth. Okay, and what I'm seeing in my community is that when those relationships aren't there, people aren't engaging preventive health care. Okay, they may access for a crisis, but there's no relationship there for preventive health, for colon cancer screening, for breast care screening, and those types of plans. So I guess in the end, my question is, how do you impact that positively, understanding that through telehealth?
Can I jump into that one? So again, I'm going to veer into my favorite topic of medical education. And to me, really, the answer isn't doesn't lie with telehealth, but the answer lies in training more doctors that look and live like in their communities, right? We need to have more African-American doctors and more Hispanic doctors and more doctors just like that look like people in our community. And there's been study after study after study that patients trust their doctors and engage in the preventative care more if the doctors can relate to them, if the doctors look like them. And I think this is really, again, something that we feel very passionate about downtown at UCSF Fresno in starting this process early. You know, it's too late by the time we're talking to college students. We really need to start in middle school, in elementary school. We need to make sure that, you know, children of all different colors and all backgrounds have an understanding that maybe career in medicine is for them, that this is accessible to them. And I think this is really where we're going to start with building trust and building access.
Thank you.
I have first a comment and then a question. The comment is that Dr. Lee and myself, we teach a course in public health department, telehealth. And that's just the beginning, and that opens the eyes for many of our students. And some of them are present here today. I think they're learning a lot. And we would like to invite some of you over here and in our classrooms. And we want to keep this relationship going. And so really appreciate your coming over here. But we do have students who are eager to learn. We have courses here, but we need your guidance, like what else do we need to teach them? Do you need to teach them, you know, like Epic or hands-on technologies, even for nursing students, like what do they need to know so that it helps you when you get students who are already, you know, ready, you know, well equipped, well trained in these areas. So, you know, your guidance, and as Nupur and I will talk to you, and we'll probably hope more collaboration, and looking forward to that. My question part is, when I was doing research a long time back, like 2008-9, around that time, and doing research on interest on telehealth, and I came across some doctors, they were relatively, you know, in the business for a long time, and they were very much opposed to telehealth. They're saying, if I don't touch and feel, I'm not going to just, you know, go and get prescribed medicine. I have younger doctors who are like very excited about that, like they love technology and all these things. Do you get pushback from your colleagues or, you know, other doctors, physicians who find difficult to get, make them convinced or like, you know, come them on board to practice medicine? And how do you deal with that? So just open, but everyone wants to get this.
I'll take this one. So as an informaticist, which puts me in the position with the folks that I work with between the end users, the care team, the physicians, and technologists, or between the end users and administration. Change is inherently bad, it's inherently stressful. And so 15 years or so ago, when I started getting into this, we were really at that transition in the middle of the meaningful use transition. And there were folks towards the end of their career who really didn't want to make that transition, and some chose not to. And for you know, if I had to make a transition now, 25 years into doing healthcare, that would be a lot harder than somebody who immediately comes out of training and is really more of a tech native, as opposed to someone who had to figure out how to weave computers into their career 20 years after they had started that transition. And so just getting off of paper prescriptions was a big challenge. Getting off of paper notes, putting down the phone and not dictating, that was a real challenge. And in the early days when we'd have downtimes, the nurses and physicians would say, yes, the computer's down, I get to use my paper. Well, we're at a point now where the last 5-8 years of physicians, of nurses, of pharmacists, of physical therapists who are coming into the system, they've never written an order. They've never dictated. They don't know what to do when the system goes down. So it creates sort of a fascinating challenge. Change management is a big part of, I think, what we all do. And that really gets to relationships and human behavior and understanding that it is stressful and difficult to go through change, and the change is inevitable. As soon as you find yourself arguing for the status quo, I would encourage you to recognize you have lost, because whatever else happens, things are going to change. And so
So as we conclude this session, you know, I think that there are three themes that, you know, that is emerging in my mind. A is medical education and education of our task force, our students. I think B is talking about delivery, how we're going to talk about what technology we're going to use to deliver. And I think C is, how we can do it in an interprofessional way. So my hope is, and when I hope with all sincerity that, post this, a panel discussion, we'll have continuity in what we can do together. And maybe it could be a start of, just a simple consortium, something that we can put together to have our students interact with each other and have that dialogue. Because, that is so important, the task force that you're talking about. And, as a faculty, when I talk to my students, some of them are here, they are very, very excited about the future. They're very excited about the possibilities of what we can achieve. So thank you so much for coming. And, I just want to thank you. And we have small swags to just say thank you to you for your presence today. No, you can.